Isn't it refreshing to start talking about innovation when it comes to healthcare instead of, oh, let's see what we can do to cope with this? You know, I thank everybody for all their presentations and for all their support. Now, what I want to do is kind of wrap things up with an overview of the legislation that is proposed, and then open it up to the floor for questions and answers. So, hopefully you've gotten a lot of a flavor to say that, first of all, the path that we're headed on right now is not the right direction. Second of all, there are options that are out there that are alternatives, that are viable, that are better than what's currently on the table in the form of House Bill 4714. And now we're going to go off and talk about that solution that sounds too good to be true, that I think Josh helped dispel some of the myths about this being something that can't be implemented, because, you know, those who are saying that it can't be implemented should get out of the way of the folks who are actually implementing it, right? All right, so without further ado, let's talk a little bit about what I call patient-centered care solution. It's fundamentally based on the premise that if we stop talking about expansion of a government program like Medicaid and start talking about the end game that we're trying to get to, which is expansion of access to quality care, when you phrase it that way, first of all, you say, I don't need a government program to get good quality care out there. Second of all, you open the door to private solutions and free market opportunities to go off and provide that access to quality care. Fundamentally, what we talk about with government assistance programs like Medicaid is that we're increasing the cost of delivering this health care, increasing the cost of the delivery system, and then asking some of our taxpayers to go off and subsidize the cost of that higher health care system for segments of our society. And I said, well, what if we could actually take a step back from that model and say if the end game is actually lower the cost for this target population, why don't we lower the cost for everybody and see if we can chop out some of the fat over on this side and lower the cost for everyone and benefit everybody. So this people that were hurting financially in the low-income crowd could get access to care more readily. And by the way, we might also help the rest of the folks in the state here, besides the 400,000 we're talking about in Medicaid, and get them access to quality care and at a lower cost. So that's where this whole thing started. Just a simple look at the end game is this lower cost? How do we do this for everybody and treat everybody equal in the state instead of just picking winners and losers? So next slide, please. So I contend that based on the model that we're talking about, based on what you've heard with these direct primary care service providers, based on the provisions of the current Affordable Care Act and this little glitch in the system here, I believe that we can push forward a solution under this Patient-Centered Care Act that provides higher quality of care. And we demonstrated that with a lot of the discussions that Medicaid is a piece of paper, but it's not necessarily quality care. And we can do it for lower costs. And I would submit that we can do this for costs on upwards with savings of 50% or more in some cases. And I would also highlight that, and this is something I get challenged on quite a bit because we do have waivers in our bill. I would contend that we have no waivers actually required. We're going to go into that in a little bit here. But I want to highlight that I would contend that for my bills to take effect, we don't need a waiver. The waivers are requested to make this bill even better. And when you look at the waivers that are being requested, really it's a case of honoring the customer in this case with better service. And that's what it's all about. And so it takes a good solution and makes it even better from my perspective. And that's the focus of the waiver. So there is waiver language in it, but like I said, I believe they're optional. Next slide, please. So the bill package we're talking about are Senate Bills 459 and Senate Bills 460. Senate Bill 459, I call it the plumbing bill. It's providing a regulatory infrastructure to allow us to check the box on things like qualified health plan and make sure we meet our minimum essential benefits. It actually establishes a government assistance portal that essentially helps us to consolidate all these different government programs and into a single location, figuring out whether or not somebody's eligible for government assistance or not. That's intended to help out a lot with fraud and waste and abuse, because right now, every single one of these programs has their own little marketing and fraud arm on it. Now, if you can actually point them or get them converging on one point of focus here, where for that one person that you determine that overall government assistance eligibility, you can start reconciling all these different programs so that they're not double and triple dipping into these programs. And then also it includes a low-income trust fund that's set up that really only has context in light of Senate Bill 460. And Senate Bill 460 is that conversion of the current Medicaid population to a qualified health plan featuring direct primary care services and a high deductible health plan, all within the wrapper of a health savings account. So for the first bill, there is a waiver request in there, and essentially right now there's a restriction upon providing government assistance to anything except for a government-controlled or a state-controlled exchange or a state-initiated nonprofit exchange or single exchange. And we're saying, well, why would you limit to a single entity? Why would you limit it to a government-run entity? We've already got private exchanges that are already in operation right now. eHealthInsurance.com is one of them, for example. And when I went off and did the analysis for this bill, I went out to a couple of different sites, actually put in a profile, got quotes back within 30 minutes. Government program, or government exchange, I wouldn't get a quote back for weeks, months, whatever. If you talk to some of our veterans, it's a pure travesty on the response time that they get for their VA health care. I don't want that happening to everybody. I don't even want it to happen to our veterans, and we're working hard to fix that in a different context. But so what I'm suggesting is that I want the only touch point between consumers and these health care plans to be in these private exchanges. I don't want the government anywhere near it. I don't want government navigators in it. I don't want them prying into patient information. I want these all to be handled via a private exchange like eHealthInsurance.com. And so all we're doing is asking for a waiver saying that we can port that government assistance out via these private exchanges. We don't have to go off and knock on the government door saying, Mother, may I, can I have access to my government assistance? Now, if the federal government says, no, sorry, we want to control that interface, well, first of all, we highlight that this is about control, not care, which I've been contending since day one. These organizations that are up here are not there for care. They're there for control. And Congressman Dingell said as much back in, was it 2009, I think it was? Yeah, he had the, so this is about control. Well, if they deny that waiver, it's this one in particular, it's obvious that their focus is on control, not care. Now, we can always work it. If they say no, we'll say fine. We'll just get you a coupon. You go redeem it at your neighborhood Secretary of State office or drive all the way up to the Department of Community Health up here in Lansing, and we'll ensure that wonderful customer experience associated with having a delay between when you actually get eligible for government assistance and when you can actually redeem that at government assistance. So technically it's optional. We don't need it to work in order for this. But the goal of setting up these private exchanges so we don't have to go to the federally facilitated exchange, we don't have to go to a state-based exchange, we don't have to go to a state partnership exchange, we can get access to that information via private entities. So we don't have anybody wearing any, vote for any particular party t-shirt going out there serving as navigators to direct people to the proper health plan. Senate Bill 460, we're asking for a waiver in there because anytime you change your Medicaid program, you require a waiver from the federal government to go off and approve your changes that you made. Well, in our case, we want an approval to go off and convert people from what is essentially poor quality care, or I should say, and I want to highlight, in regards to the Medicaid program, Michigan does indeed have one of the best Medicaid programs in the nation. That doesn't mean that it can't be improved upon significantly. It's all still based on an HMO model. And I think Colbeck actually highlighted exactly the trials and tribulations of a managed care model, whether it's managed by a private company or managed on top by a government entity rather than a doctor-patient relationship. But having said that, we believe that when you go off and that you can save a significant amount of money while improving care by converting to this direct primary care model with a high deductible health plan for catastrophic insurance. If the federal government says no, that won't work for us, it's really what they're saying no to is the idea of, first of all, saving taxpayers money, and second of all, they're saying no to the idea of actually providing Medicaid, current Medicaid recipients, and that's the only focus of this, current Medicaid. It's not expanding or anything. Current Medicaid recipients, they're saying that you don't deserve better quality care and that you're not going to get better quality care, even if it does save us more money. So they can say no to a plan that goes off and denies people lower cost care for a higher quality. They can go off and do that, but let's see them defend that. So if they do go off and say that, once again, it just emphasizes that, once again, it's more about control, not care. But second of all, there's another option that's available to the state. The federal match rate for Medicaid in the state of Michigan is around 60%. Currently, we spend about $5,000 a year on just a single, it varies by population, but take the single adult population that's a primary beneficiary of Medicaid expansion. $5,000 a year the state of Michigan pays on that. That's per Senate fiscal. The plans that we can go off and identify here for direct primary care plus a high deductible health plan can cost as little as $2,100 a year. So that's almost a 60% saving. So you've got a federal match, 60%. You've got potential for 60% savings here. Federal government says no, we don't want your waiver. Well, we might be able to say we're in the ballpark. We got to do some detailed financial analysis, but we're in the ballpark where we may be able to say no to the federal government and opt out of Medicaid and still take care of our citizens that are currently under Medicaid with only state dollars. So I kind of like that, the sound of that. And then there's also the third option, which is we just maintain the current system and we don't save the state money. We don't put people into a better healthcare system, but we still go off and put in the plumbing for a free market system down the road. So there's a few options there, and none of those are required, but like I said, it keeps moving the needle to make this better and better and better for the citizens of Michigan. So anyway, next slide, please. So I wanted to end this portion of it and then open it up to the floor for Q&A across the board here, but I wanted to end with a comparison between House Bill 4714 called Healthy Michigan and Senate Bills 459, 460 called the Patient-Centered Care Act, which I'm starting to call them Healthy Michigan and Healthier Michigan. So I just want to kind of highlight some differences here. So first of all, under 4714, they expand Medicaid. They expand government assistance, and by doing so, they're enabling Section 2001 of the Affordable Care Act. Central tenet of the Affordable Care Act is Medicaid expansion. It's their path to a single-payer system. And I'm diametrically opposed to pursuing any monopoly of our healthcare system, especially a monopoly by the government. Monopolies have always demonstrated to lower quality and increase costs, and that's not what our citizens deserve. And our approach is that we expand access to quality care without expanding government assistance. We've already beat this horse to death probably, but I would contend that you get poor quality care with Healthy Michigan, and you get better, higher quality, commercial grade care with an emphasis on preventative care under our direct primary care model. The third item here is that in Healthy Michigan, like we were talking about at the beginning, you have higher cost health care for everybody, and then targeted subsidy in order to pay for subsidized health care for the winners of Life's Lotto here that actually are the winners and the targeted segments of population that are determined to get government benefits. Our approach says we believe that we represent more than 400,000 people in the state of Michigan. We actually represent 10 million people in the state of Michigan, and we should be seeking solutions that lower the health care costs for everybody. Healthy Michigan, 4714, goes off and increases government spending. So as Ovik was talking about, we're currently at 45% of our budget right now is dedicated to health spending. They want to improve or increase that by another $1.5 billion, almost $2 billion. And granted, they'll say it's federal money, but I don't know about you guys, but I don't know if the dollars that I have in my wallet here say this is only federal money or this is only state money. It's still coming out of the same people, you and me as taxpayers. And our proposal, we can cut government spending by as much as $7 billion. I don't know if it's going to be $7 billion or not. We've got to go off and do the detailed financial analysis. But just based on the numbers that I've shared with you already, there's a significant opportunity, and even Senate Fiscal has come through and said that there are savings associated with our proposal, and these are total savings, not just state savings versus federal savings. These are total savings. And I think, and we're actually providing better care in the process. Who'd figure in government, right? I would submit that the 4714 actually increased our debt risk, and Ovik showed slides that show, yeah, we're fat, dumb, and you know what, for the happy for the first, what is it, how many, 4 years, 5 years or whatever, and But after that, things start getting real bad for folks. So how many of you guys remember the old Popeye cartoon? What did Wimpy always say? Gladly pay you Tuesday for a hamburger today. Well, eventually Tuesday is going to come home to roost here in the state of Michigan. And, you know, we're already there at the federal level, I would submit. I think we've started getting our arms around the problem here at the state level finally. But I don't want that to happen down the road here. We're 5, 6 years, 7 years from now. And that's under the rosy projections of their actuarial assumptions. I don't want to be sitting there having to increase taxes to pay for something that we did not make the tough choices right now to say that we're not going to be Santa Claus and actually go off and preserve future generations so they don't have an increased debt burden. So I would submit that because we are not expanding government assistance, we actually lower the debt risk for future generations. That's a key differentiator. Now, if you're talking about risky implementation here, you know, some of the people have characterized our plan as, oh, too risky. You're trying to change the whole healthcare system in the state of Michigan. Well, first of all, we demonstrated that people are already doing this model. This is not, and we haven't even got into California, which has one of the biggest direct primary care models that's already out there. And all the assertions that we're making here have been validated by folks out in California. And let's just say they're not on the same side of the political spectrum that I am. All right? So those opportunities are out there where they're already showing a reduction in the number of ER visits because people are going to primary care. 40 to 80% have been demonstrated by Q-Liance. They're a major direct primary care provider out in the state. So instead of increasing the number of ER visits, which we're going to get when you put our Medicaid population into the, or when we're going to expand Medicaid under 4714, we're actually going to lower the overall incident of seeing the ER. And I wanted to highlight, too, when we were talking with our folks from Atlas MD, what their experience has been in that regard. They don't invoke those deductibles. They don't invoke that catastrophic care element as much as you do under the traditional model. So I would contend that it's a very low-risk implementation. Now, we don't have a robust direct primary care market right now. Matter of fact, Blue Sky Health is one of the first to venture into this. We've got some higher end, if you will, concierge services, they call them, for C-level execs and stuff that provide the old metal alert bracelet. If you sneeze, they come in and provide a tissue, you know, and a napkin or whatever. That's a high end. That's kind of like the Maybach, if you will, of healthcare on it. But we still need a mid-range for the rest of us here, if you will, that actually provides good quality healthcare across the board. One of the ways of doing that is by Senate Bill 460 and preceding that market with adding 1.8 million Medicaid patients into that market that encourages doctors to come out of the shelter of the current hospital-based system. And they all went there because of the overhead that you heard them talking about here. Now we can say, guys, the water's fine. Come out back in the private sector and in your private practice, and we're going to have a ready-made market for you that's going to help all of our citizens. You know, Nancy was fantastic highlighting the opportunity in regards to job growth here in the state. And, you know, when you start getting to the point where Michigan's healthcare costs are 20, 30, 40, 50% lower than Wisconsin, Indiana, Ohio, what do you think that's going to do from a jobs perspective? It's huge. And we got to be all in on this in order to get those benefits. If you just kind of nip away at the edges and say we're not going to go off and encourage a direct primary care market here in the state of Michigan, well, then you're just going to nibble away till eventually you'll get to those types of savings. Fundamentally, what the 4714 is doing is it's converting uncompensated care to undercompensated care, not fully compensated care, undercompensated, and then so essentially throwing, as Ovik was talking about, throwing kerosene on the fire for our current quote-unquote uncompensated care issue with cost shifting. And what we're doing fundamentally is converting uncompensated and undercompensated care to fully compensated care. Now, I'm not proposing that all 400,000 people that are supposed to be benefiting from the Medicaid expansion are going to be covered under our plan because they won't be able to afford it, but a significant portion of those people will be able to cover it that couldn't afford it before. I don't know what the exact numbers are. I guarantee whatever number I throw out on that is got as much certainty associated with it as the numbers associated with 4714 saying that it's all going to balance by the end of the day. But what I can tell you is that the overall reward for everybody in the state of Michigan is going to be benefiting, not just the likelihood of more of these people getting into the fully compensated care area. Now, we had an other care event. I didn't talk about this that much, but this is essentially a mini other care event that we had for today. Out in Ann Arbor, we had physicians from all across the country and all across the state of Michigan, all the way up into Escanaba, et cetera, that came down and talked about different opportunities for free market alternatives. Well, Dr. Seema Verma was there, and Dr. Seema Verma is the architect of the Healthy Indiana Plan. And one of the nuggets of information that I got from her presentation was that they've gone off and done surveys on their Medicaid population, the Medicaid population up to 100% of the federal poverty limit, and the Medicaid population from 100 to 133% of the federal poverty limit. And one of the very nice little tidbits that she walked away with at the end of that was that 100% of the folks from 100 to 133% of the federal poverty limit would pay $20 to $30 a month if it meant that they'd have access to good quality health care. So it's not like they don't have any money, but they've gotten some money to be able to put in there. And so that money could actually be put towards, when you put it into the free market and you start getting different options, when we start talking like Tom was talking about, there's going to be people that are going to be interested in saying, hey, I'm going to find some way of pulling in this Medicaid market and tailoring plans that actually take advantage of some employer subsidies that are going to be out there as well, and have people put some skin in the game with their 20 to 30 bucks a month for these direct primary care models. And now you start opening the door to care to people that before didn't think they could afford it. And I think that's pretty powerful incentive. So I'm not going to say we're going to insure everybody here, but we're going to make it more likely that they're going to be able to get that access to care. And let's say they don't do any of these direct primary care monthly models, monthly subscriber models or anything. They're still going to get to the point now where you can walk into a doctor's office and see a price up on a screen and see what the value meal price is. And you're going to actually see, you're going to have that cost transparency. So if they go in and pay out of pocket, they're going to understand what that is. And you're going to see some cost pressures that are going to push down those overall costs across the board. And if we extend this model, frankly, into surgery and some other procedures besides just primary care, huge opportunities. That other care, just to give you an idea of what the opportunities are for if you extend this model into procedures like surgeries, surgery that was cost $175,000 typically anywhere in the country. In Oklahoma, at this Oklahoma Surgical Center, that same operation costs on the order of $16,000. No quality issue. They got people from all over the country, all over the world coming to here for this quality care, for these surgery procedures. That's how much bloat we have put into the system via government regulation and via all the resulting insurance administration that comes as a result of all this government regulation. So we've got a huge opportunity here. So I also want to highlight, that the 4714 promotes that current third-party payment model with minimum price transparency. Like I was just talking about, when you go off into this model, you're going to start seeing, if you go to the website, to Blue Sky Health, go to the website of Epiphany Healthcare in Florida, go to the website out at Atlas MD, their prices for everything that they're providing and the services that they provide are up on the web. Where can you find that in our current model? Nowhere. So the more we encourage that, the better off it's going to be for everybody. And last but not least, Healthy Michigan promotes big government solutions, patient-centered care, limited government. We actually put the genie back in the box. Senate Bill 459 explicitly limits the role of government to this government assistance eligibility determination. They're no longer talking to our customers, i.e. the citizens. They're not collecting patient information on BMI or cholesterol levels or anything like that, so that, what's that lady's name that's in charge of Obamacare now? No, not Kathleen Sebelius, the one in the IRS. Yeah, Lerner. Yeah, well, I don't know if she's officially in that position anymore. She was appointed to that position. I don't want her having that data. Sorry. I'd rather give it to Matt and to give it to Rob here. So I'm a little concerned. When you actually look at the actual tenet of 4714, what they've done essentially is saying they're going to take in the current contracted health plan model in the state of Michigan, which, like I said, is one of the better ones in the country. But they're taking this HMO managed care model, which, by the way, as we talked about earlier, they make money by rationing care. That's essentially what managed care model is. Now we're layering on another layer of government bureaucracy to make sure that we manage the managed care. All right? So it's taking a bad situation and making it worse. And what we're doing in the model that we're proposing as an alternative, we're saying, government, I don't want you talking to my clients here at all. We want you to, you know, they're going to be patient decisions that you get to make on your own. We're going to promote the idea of a robust direct primary care model, which puts, once again, the patient and the doctor relationship at the center of our healthy outcomes in the state of Michigan. And the goal is, you remember those old paintings here with Norman Rockwell, with a little doctor saying ah with a little patient, a little pediatrician model here? That's kind of that's the model we're trying to get back to, you folks. And it's not like it never worked. It worked for so many years. But all of a sudden, the government got in there and decided that they're going to try to cure everybody's ills. And I got to tell you, we're giving up our security bit by bit by bit in favor of this big government here. And what did Benjamin Franklin once say? He said that those willing to give up a little bit of liberty for a little bit of security deserve neither. And that's what we're doing right now. I want to take care of all the world's ills, and to do so, we're only pumping government solutions, government solutions, government solutions. It doesn't work, guys. And you know, back in 1965, before we kicked off Medicare, healthcare costs were 5% of our income. Now what are they? They're sitting around 40, 50% of our income right now. Actually goes into healthcare costs. And those are all programs that are designed to lower the cost of healthcare and make it more affordable for everybody. I'm here to tell you guys, this direct primary care model is a game changer, as Tom was talking about here for the state of Michigan. And I urge your support and your contact of elected representatives to help get this over the finish line. So with that being said, thank you very much for your patience and coming out here on a rainy day, and we're going to open up the questions and answers. Yeah. So if everybody could just kind of line up over here, and we'll try to take everybody in sequence. And I want to also thank again this panel and Dr. Doug. I know I still see the back of your head out there, but he's making a house call. But I want to thank everybody for coming out and dedicating time to go off and support this event and help get the word out. This is really just about getting the information out, and you guys are the key to making that happen. I'm just one lowly elected officer, and this is another elected official here, but we're two out of, let's see here, 110 out in the House and 38 in the Senate, and the more we can get this amplified, the better. So thank you very much.
Thank you, Senator. My name's Dr. Chad Savage. I'm an internal medicine doctor out in Brighton, and I can just say, I absolutely understand that more jobs could come to Michigan, but if you free doctors of that bureaucracy, you'll get more doctors coming to Michigan too.
Yeah, thank you. It's a good point. Yeah, and I kind of want to highlight just a quick metric on that. You know how we're always talking about the chronic doctor shortage we have in the country? Well, people estimate anywhere from 20 to 50% of a doctor's time is spent on overhead activities, as CPT coding, things that are not directly related to seeing a patient. Well, if you just took the low end of that, the 20% number, and applied it nationwide and said, you don't have to do that, spend time on that overhead anymore, you'd have an effective 160,000 more physicians in the country. That's huge. Sorry, Jack, go ahead.
Hi, great presentation from all of you. I have a quick question for Patrick and Nancy, and an invitation for Obamacare to get into hospital pricing and cost a little bit. But first I want to just share one quick news item and one observation. The news item, today's Michigan Capital Confidential reports on what may turn out to be Michigan's Diamante driver story. The patient is hanging on, so hopefully it won't become perfect analog, but a woman on Medicaid who couldn't get care for a tooth issue, and it ended up in brain surgery, now is in intensive care. Observation, it struck me listening to your presentation that I now understand the difference between state dollars and federal dollars. State dollars come out of your pocket. Federal dollars come out of your children and your grandchildren's pocket. Quick question for Nancy and Patrick, and it is, are the House and Senate going to move those Navigator licensure bills that will, pretty effectively cramp the style of acorn type operations that want to get into the Navigator business? And I'll go ahead and pose my invitation to Colbeck. The hospitals here are what's driving, are where the energy for the expansion is coming from. And, you know, in economics, there's the concept of revealed preferences. Watch what they do, not what they say, right? Well, these hospitals are revealing all up and down the halls of this building all year long that they're going to make a lot of money from this expansion. That said, you know, Patrick mentioned the difference between the Oklahoma Surgery Center prices and the mainstream prices are evidence that there's so much bloat in the mainstream hospitals, so that I think I heard you or you know, one of the guys in one of these presentations say that, maybe it was you, Patrick, that yeah, I'm sure the hospitals are stressed to make their budgets balanced, but you know, it's such a black box operation where the costs and the revenues have absolutely no relationship to anything that resembling market forces. It's just it's a total black box. So basically, I'd like to hear you comment on that. You know, they pour mouth incessantly, these hospitals, and yet we all know in the last 4 years since the crash in 2008, where do you see the climbing cranes on city skylines? It's almost always a hospital. So that's for a starving beast. That's quite an operation.
So let me try to summarize. But I mean, it was two key things are the Navigator bills, and also if Ovik, if you want to talk about the hospital. Well, I wish I had something to say on the Navigator bills. I don't know right now. Frankly, my own whole world is revolving around these two bills right now. So I can't. I got to admit, I got the horse blinds on with this right now.
Not until October 1st, and those
All right.
people are going to be in front of the door.
Got
I
that,
just want to say
Justin?
my comment would probably be about the same as Patrick's, so we'll have to check on those and get back with you on that.
It's a great idea to license Navigators, actually. I hadn't heard of that before. I hadn't heard of any state actually considering that, because it is a huge, just so people don't know what Navigators are. Can you turn off that mic? Maybe that's the feedback there. What you may not know is that the Affordable Care Act creates these positions called navigators. They're paid positions for people to help enroll people into the exchanges. But there's no specification as to their training. There's no guarantee that these individuals will actually make the right decisions. Like if they enroll you in the wrong plan, you could face $25,000 fines from the IRS for non-compliance. There's no requirement that they safeguard your private medical and financial information. So there are a lot of problems. You're basically relying on these navigators to enroll in the Affordable Care Act's plans without any assurance that any of your information is going to stay safeguarded. So I think it's a great idea to license these navigators to ensure that these people are actually, if there's a regulatory burden on them to preserve your records and know the law well enough to not make mistakes where you're financially liable if you make a mistake. Let me just go to the. And in that way, I think that's a great idea, and it also prevents it from being a slush fund for activist groups who are basically trying to take this money as opposed to use it for actually for helping people. On the issue of hospitals, so in the current issue of National Review, I actually have a lengthy article on just this topic. It's the yellow issue for those of you who read National Review. It's called An Arm and a Leg, and you can also download it online from the National Review website. And it describes this whole problem of how hospitals are the driver of all of the inefficiency in our healthcare system. Because for every dollar that we spend as a country on healthcare, 40 cents of that is spent on hospitals. For every dollar the government spends on healthcare, 40 cents is spent on hospitals. So what do hospitals want? They want more taxpayer resources spent on healthcare, because 40% of that goes to hospitals. So that's why they lobby. They're a massive special, they try to portray themselves as these disinterested pillars of the community, but they are a massive special interest that is trying to encourage taxpayer dollars to be funneled to them. And that's why they're lobbying so heavily for this Medicaid expansion. But when I was here 2 weeks ago testifying before the Senate with Senator Colbeck, one of the hospital executives, I believe it was a CEO of Spectrum Health, I don't remember now who it was, who admitted under questioning that they lose money on every Medicaid patient who comes through the door. So, And part of the reason why there's this kind of, well, wait a minute, if you're losing money on every patient who comes to the door on Medicaid, why do you want the Medicaid expansion, which I think is what Jack's getting to? A lot of it has to do with the way hospitals manipulate what they charge to different patients with different insurance status. So to those of you who read this epic article by Stephen Brill in Time magazine called A Bitter Pill, where he talked about this problem, where hospitals, nonprofit hospitals, right, the people who are supposed to be only about helping people, are charging $300 to a patient for a bottle of vitamins that you could buy at Walgreens for $2. They're charging, $300 for an X-ray that costs like $20 or $10. They're doing this because that way they can say they have all this uncompensated care and then demand more tax dollars to subsidize it. So those charts I showed you with the amount we're spending on uncompensated care, those are based on what the hospitals are telling us. There's no audit of that number. We're trusting their word, say, well, that's the care that they're not getting paid for. But it's a hugely exaggerated number because hospitals overcharge for a lot of things and then say, this woe is us. You'll notice that they say this, that hospitals are just struggling all over the state, all over America. They don't get enough money. But where are all the new buildings being built in this state and every other state in the country? Where are all the fancy new glass and steel towers? It's hospitals. The same time hospitals are say they're losing all this money, they're building new wings and expanding. So how can that be? And that's because hospitals really are, it's larger. People like to complain about the military-industrial complex. The government of the United States, that is to say taxpayers, spend more money subsidizing hospitals than they do on the military-industrial complex. That's how big hospitals are driving federal spending on healthcare and federal spending generally. So it's a huge problem, and I think it's really important that when you hear a hospital executive talk about how important this is, that we raise the point about the massive financial conflict of interest hospitals have in lobbying for taxpayer dollars being funneled to them that could go to more efficient delivery of health care.
Come on up there. Rick, you want to come up? Yeah, thanks, Cheryl. I don't think it's turned on.
To your point, Mr. Roy, Patrick, we write to our representatives. Mine will acknowledge my minority status in his area. He's against 4417, was it, or 1477? Okay. How do we get a fair hearing? What about small business? How do we get them as a larger group with some economic impact to hear this story and sell them before October 1st? Because I just can see that in the state Senate, some of these guys will have so much pressure about lobbying money and can't contribute to campaigns. How do we influence that? And I notice in the media, they don't even want to expose the subject like national popular vote unless you're on the inside. And the other thing is, I heard you for that 4 minutes, if not 3, with Paul W. Smith, and you got a short shrift if I ever heard one. Doesn't sound like he's too interested, so I'm writing to WJR about that.
Thanks, Rick. Well, first, let's get a little bit of background on the timing of this. So it's not till October. It's not October that we have to. It's August 27th. It's even shorter. And in fairness, I mean, Senate Majority Leader actually did put this up for a vote out at the Government Ops Committee. Where these bills sit right now is actually on the floor of the Senate because the Government Operations Committee actually reported out this bill. They also reported out 4714. They also reported out Senator Caswell's Senate Bill 422. So right now, all 3 of these options are sitting on the floor of the Senate. So you can make the case. We had a hearing for the bill in government operations, probably about an hour and a half worth of testimony. There were crickets afterwards, for the most part. But I think people were stunned by the fact that this actually is viable, and it's got some teeth. It's got numbers. It's got data. It's got it's something that's already been working in other areas of the country. And I think what we need, I mean, purpose of this event right now is making sure we get out the information so that our fellow legislators, our folks in the grassroots, that everybody understands what we're proposing here better than we've been able to communicate just by one-on-one emails and by me going out to different committee hearings and different forums throughout the district. We're just one person, one representative, and we need some force multipliers. So we're hoping that people here like what they hear and that they are turning into that multiplier where now you guys can say, I've heard what they have to offer, we like it, or this work can be improved or whatever. And I'm not saying we don't have room for improvement on any of this, but I got to tell you, I got less room. There's more room for improvement in the 4714 bill than we got in this one right now, and ours is a lot simpler. So I think the best thing is to, right now, get the letter writing campaign. But more importantly, I would suggest if you like what you've heard, and if you don't, I mean, let me know about it. But if there's areas we think I can improve, but if you like what you've heard, get it out into the paper, because what's happening right now is that we're not getting any coverage of this. Whenever they talk about Medicaid expansion, they're only talking about 4714. It's like we don't even exist, right? So I think we need to get it into the. I mean, it's not like I'm not putting out op-eds. It's not like I'm putting out press releases. It's not like I'm not putting out columns. But if we're ever going to get this, President Reagan needs to go directly to the people. And that's what I'm trying to do right now with events like this, to get it out directly to you all and say, guys, we need your help. And it depends on your assistance to get the word out to everybody. So anyway, thanks for bringing that up, Rick. I mean, this is all I know is I'm giving it all she's got, Captain. I can't give it no more. And we're really working hard to not only shore up the legislation, but also move forward on the PR and build a coalition so that when this comes back into the House, we've got the votes to pass it out. So that's where my focus has been. So it leaves very little room for the PR part. That's where all you can help. Yeah.
The math, with the partisan makeup of the Michigan Senate, I believe it's only 8 Republicans who need to vote, and 7 Republicans need to vote in the Senate, because all Democrats will vote for 4714. So it's a pretty small number of Republicans who need to vote for 4714 for that to go through. The majority, 2/3 of the Republicans in the Senate don't have to vote for it to go through. So if I were to advise you on what to do, I'd advise you to focus on those legislators who seem most supportive of 4714 on the Republican side, and try to convince them to take a pause and take a closer look at this legislation instead of letting the train leave the station. I think if you focus your energy there, that's going to be where you're going to get the most bang for the buck.
Yeah, I can speak loud enough for everybody to hear. One of the concerns that I hear from the conservative grassroots in the state is that Senator Colbeck's plan is actually a backdoor approach to implementing Obamacare. Colbeck, would you address that, please?
I would say it's quite the opposite. I think that if you implement this approach of saying that we're going to have direct primary care, where poor people, wealthy people, and everyone in between can get actual health care, what we are doing in this state will be ground zero of a revolution in healthcare, a free market revolution in healthcare. We will show every other state in this union that there is a cheaper way to deliver high quality healthcare with better outcomes at a fraction of the cost. And if we can do that, then we will have not only the financial numbers to back what we're doing, but we'll have the moral authority as well to say we have a better solution, not only a better solution for taxpayers. I think a lot of times conservatives focus on the dollars and cents and don't focus on the healthcare system. We have a terribly inefficient healthcare system in America. Government spending on healthcare in America before Obamacare was more than all but 3 other countries in the world. More than the UK, we always say, oh, these European countries, we don't want to be like them. We should repeal Obamacare. We were already spending more than those other countries on health care, taxpayer dollars. So this approach will, undermine, like, these terms can get thrown around, but you can go two ways. You can say no and try to block things, or you can propose a solution that can move things in our direction. Whatever you do to not implement Obamacare is still going to get implemented either way, with or without you. But if you provide a solution that's better, other states look to Michigan and say we can do that too, it will spread like wildfire.
Follow up on that for a second. I think it's too, this is not crazy thinking. The two most competitive economies in the world, according to the World Economic Forum, are Singapore and Switzerland. How do they differ from us? That's because they have basically a consumer-driven model where the individual has choices for how they get their health care, and they get the monies to spend for that health care. Now, they have their other limitations. Don't get me wrong. I'm not saying they've figured everything out, but in that regard, they've figured out health care. And so I think if you emulate those countries, you're probably going to be fairly competitive moving forward. Also, on the private sector, I don't know if, it was kind of passed over, but I think the folks at Atlas MD were talking about ERISA plans. The private sector's already, thank you, solved this problem. They're already moving on to high deductible health plans with health savings accounts because they can't print money. They have to be competitive. And by doing this self-insurance plan, and you don't see much of this in the press, and I'm very surprised, this allows them to not participate with the Affordable Care Act at all. They actually fall under the insurance ERISA guidelines of 1987, and they have a lot more latitude in how they design their health plans for all their employees. So that's why you see guys from Honeywell and what have you with these credit cards for their health care. They're already doing this. That marketplace is already happening apace. And it's whether, our entitlement programs follow suit, but it's already happening in the marketplace.
Can I piggyback on that just a little bit? And it's something that Josh talked about briefly, talking about whether or not they're going through the exchange or not. What's actually happened because of this bloat that's out there is that you're seeing more and more, if you would call it black market services that are going on. That's usually a first indicator that you're over-regulating something, is when things have to go off the grid. Now, I'm okay generally with getting off the grid. Don't get me wrong on that stuff here, but I think it's one of the key indicators for why companies such as Blue Sky Health are starting to pop up and say, this is something we want to go off and embrace. It's gotten so ridiculous on the regulation side of the fence that it opens the door for this. So, anybody else? Yeah, go ahead. Yeah, a complete list of service providers is always useful. We know of a few already. Matter of fact, I met with one of the major service providers in Southeast Michigan this morning. So, yeah, if you've got a list of that, and all this direct primary care service providers, Tom, saw, this is to show you how grassroots this proposal is. Tom contacted me after he saw, I think it was the op-ed I put out, yeah, he saw the op-ed. So the one that got in the paper. And so that's how it's gotten out here. This is just bubbled up. So if somebody's got a nice little catalog that can be shared that we can use to help get the word out more effectively, I'm all ears.
And Senator, there's a website, DP Care, I believe it's dpcare.com. It might be .org. I'm not sure, but that lists all of the direct primary care providers by state.
Oh, okay, great. Thank you. Yeah.
Concierge, and I think that there is a difference between direct primary care and concierge. Yeah. Well, one of the problems I have with concierge is it actually continues the fallacy that primary care has to be expensive.
Yeah, you're right.
And in fact, it doesn't.
Yeah, ideally, you've got a whole spectrum of offerings here. That's what the free market's all about, right? You get your you get your McDonald's cheeseburgers as well as the high-end Ruth Chris Steakhouse, right? Yeah, I've had too many of those lately here. So, yeah, go ahead.
Questions. One is, how is your bill different from 4714 if Obamacare is repealed or defunded? And number two is, could you just speak to a little bit more on your low-income trust fund, where the money comes for that? How the money is dispersed, what monies would get deposited in this.
Yeah, Alex, can you pull up my presentation, go to one of my backup slides on the overall care model. Well, first of all, I'm trying to design this so that when Obamacare goes belly up, we've got a system here in the state that keeps government bottled up into just government assistance eligibility determination with the government assistance portal, and allows us to be in control of the provisions around what is a qualified health plan. By the way, this is just a start, just so you know, on the repeal of Obamacare. There's a lot of other things that I'm not a big fan of, like certificate of need and the whole idea of a national mandate on health care, and frankly, a lot of the state mandate provisions as well. So there's a lot of things that get into, we don't really have a free market health care system, no matter what happens on this. We don't have it today before Obamacare goes in. But having said that, what we're doing here, and if you could go, keep going, there you go. On the right-hand side there, that's essentially all these little Lego blocks are service providers like Blue Sky Health that provide direct primary care, traditional insurance plans, like Blue Cross or Aetna or anything like that. They're all part of this free market conglomeration, all these little Lego blocks. If Obamacare goes away, we still have those free market options that are out there. These private exchanges are things that we already have out there today. There's called ehealthinsurance.com, and I forgot the name of the other one that I went to go off and fish from. So that's stuff that's already existing here already. So it's not like we're adding anything. The only thing we're doing is on that government assistance portal. And like I said, for me, that's a lot of it is born out of my pain points with dealing with the VA system right now, because we've got so many different programs. Each one of them has its own marketing touch point on it. Our veterans, when they see all these different options that are out there, they get overwhelmed because everyone's got a unique brochure, and we don't have a single point of contact. Well, we just recently created a Veterans Affairs agency to consolidate that and have that single point of contact. That government assistance portal essentially helps us do that on the back end side. It's not direct customer facing, if you will, but behind the scenes, it provides that same function. So that infrastructure would still be in place to help us reduce fraud and consolidate or share information with those exchanges. But really what happens is we get more flexibility on what gets offered in those exchanges, right? We get more free market, which is where I'd love to be. The low-income trust fund, it only has context and it only has meaning in context of Senate Bill 460. So the low-income trust fund was essentially set up to provide a, when I said that we save, when you convert our current Medicaid population to a qualified health plan with direct primary care, it's $5,000 gets converted to $2,100. Well, there's still this kind of a one-time seeding of a gap fund, if you will, for when people have to invoke their deductible. That the savings you get in that conversion from the $5,000 to the $2,100, a portion of that's actuarially sound to cover the gap insurance for this deductible coverage, gets deposited into that low-income trust fund. And so the goal is that the current Medicaid population would not have to pay out of pocket if they had to invoke the deductible, and that's what that trust fund set up. Nothing for anybody besides the current Medicaid population. They're not eligible. It's only focused on that current Medicaid population. And just to give you background, for a $5,000 deductible, the gap insurance runs about $35 a month, to give you an idea of relative costs associated with it. So we're not talking about a significant dollar amount that has to get in there for the population. So that answer your question? Okay. Anything else? Yeah. Come on, Chris.
Thanks for doing this. So do you have any of this information recorded so people can reference it, those working people, et cetera, and can you indeed do that, share your PowerPoints, et cetera?
Now this is on Senate TV, right? I think so, and if so, I think we can retrieve the archive. Jen, Chris was just asking, is this being recorded? Okay. Yeah.
And then also, how is City
That's where
Hall?
Jen gets to go off and say what the senator meant to say was. Yeah.
All of a sudden is on vacation and not doing anything.
Yeah.
I
forgot my sunglasses in the car.
Right. Your Bermudas look great. What type of support? You're getting any calls, friendly gestures from House or Senate folks that have not come out necessarily publicly?
From all my Senate colleagues that I've talked to, and it's probably you know, around 6, 7 that I've talked to directly. I've left messages on a lot of other phones. They've all been supportive of this bill. As a matter of fact, this is the one that they want to vote on. So that's encouraging. Now we're working on the House as well, and I've talked to probably a like number, at least 7 or 8 different reps in the House that are very interested in this as well, including some folks who voted on the previous 4714 coming out of the House that want to shift and get back on the right team. So, so I think the trend line's there. Now it's a function of timing. So if they're going to vote this out on August 27th, or if they're going to vote one of these bills out on August 27th, you know, it's going to be like, let's make a deal, and which curtain's going to open up before us. I don't know what curtain that's going to be right now, and the reason I'm here is to lobby like there's no tomorrow to make sure that we can make sure that it's door number 3. So. I know you had one, so I just want to make sure everybody else has had a chance here.
I don't want to jump anyone.
All right. Do you all set? Okay. Yeah, come on up, Larry. Sorry. Yeah, we'll get you there. Come on.
Do you have any type of white paper or anything that walks through the savings and the assumptions that you've illustrated here today? Maybe it's in your your supplementary
All I've got is a PowerPoint, because that's the fastest thing I think in right now, and I've got snapshots based on that. I've done several columns that summarize it, but there's not something that I would consider is a, my traditional white paper as a consultant in my consultant days.
Your panel experts, when they can be available afterwards to have any one-on-one
I
conversations?
don't know. We kind of like to hide these guys. It's yeah. I think most everybody here is ready, and if you want to ask about the latest Atlas Shrugged movie, I'm sure. I'm sure we've got them all pulled together here, but yeah, I think most of the folks here can be available for questions. I think we got the room till 4 o'clock. We got the room till 3. Oh, we're okay. Well, they're out in the hall. We may have people available for questions. And like I said, for the folks out at Atlas MD, we got contact info.
You spoke to that inverted triangle showing the primary care centers.
Yeah,
That's a very effective. I'd like to get. Is that part of the packet or no?
Not too. We can make it available. We'll put it part of our care package.
Actually, I could put it on our website, blueskyhealth.org. Yeah, and in fact, if you look at a lot of the big businesses that Dr. Matt was talking about, shifting to high deductible policies, a lot of these self-funded plans are putting on-site clinics in their workplace because they see the power of primary care in affecting the downstream costs. So if you look at companies like Intel, IBM, GE, they're all doing this. So why not, as a state, we do something similar?
Okay, Jack, can we do it quick, and then they're going to kick us out of the room.
Real quick. Answer the question about white paper, whatever. I just want to share that, when I first read your bills and tried to sit down to describe it for Michigan votes, I was scratching my head. And what unlocked the key for me is an article by the same guy who wrote this one that Patrick has over there, Dave Chase, about a year ago, in which he describes this as 2 parts Marcus Welby and 1 part Steve Jobs. So and it's a short article, it's just 600 words or so. And that one, it's like, okay, now I get it. Yes, this is plausible, this makes sense, this could work as advertised. So just Google Forbes, Marcus Welby, Steve Jobs, and it'll pop right up.
Thanks, Jim.
Also, this is about 10 days out of date, but 7 of these 15 GOP congressional district committees had voted at that time, this was in MERS, resolutions against the expansion. I'm thinking a few more have. Lano's here, Livingston County GOP establishment did the same. I have to think this is going to have a powerful impact on legislators, because it's one thing when you've got a few Tea Party leaders that may or may not have troops, making a case. And it's something else again when you got the beating heart of your own party's local establishment infrastructure saying, you know, getting crosswise with that latter group is something I don't think any Republican legislators want to do. And then finally, you know, maybe the House will pass, or the Senate will pass their S7 or S20 or who knows, 4714, but then it's got to go back to the House. And Representative Jenkins, you know, it's been remarkable that of the majority of House Republicans who voted no on this, and I don't know if the House caucus realized the majority of them were not in favor of the bill when Speaker Bolger ran it, but they're aware of it now. And yet none of them have spoken up to take a leadership position and coalesce that majority of their own caucus who opposed. So I'm delighted to see you here and getting involved with Senator Colbeck. And, you know, and I'm sure they didn't know that the Senate wasn't, in fact, odds are they were told, yeah, the Senate's going to vote on this right away. Well, that didn't happen. So now you got all these guys that walk the plank and are hanging out in space all summer long. They cannot be feeling real warm and friendly on either side of that vote toward this bill. So whatever the Senate does, you know, I don't see it as an automatic no-brainer that the House is just going to fall into line a second time. So,
yeah, well, Jack, we're okay if all those guys who voted 4714 come on over to this plan. So I'll be perfectly happy with that. So thank you guys, everybody. I appreciate y'all coming out here, and thanks for bearing with us.